Okay, so hello everybody. My name is Sean Roden. I'm a flight surgeon at NASA, and today I'm just going to give you a real high-level overview of space medicine and what a flight surgeon's role is in supporting the manned spaceflight. So the overview is going to give some hazards of space radiation, some interesting changes when a human goes into microgravity with the space physiology. I'll discuss some of the medical care capabilities on the International Space Station. I'll talk about the post-landing changes and concerns we have when they come back to a terrestrial environment. And then I've been a Star City physician for over 6 years total. So I'll give you just a brief overview of that because we're really entering an exciting new phase of human spaceflight for the US program. And I'll just give you a little touch of what we're going to be doing in the future. That's not part of the slides, but I still want to give you just a little taste of what are things to come. How do you become a flight surgeon? First, you have to obviously go to college, and then you go to medical school. After you complete medical school, you need to do a primary residency in any type of specialty. At NASA, we've had pretty much a representation of every single specialty that there are offered. We have preventive medicine, we have psychiatry, general surgery, urology, OBGYN, family medicine, emergency medicine, internal medicine, orthopedics, pediatrics, actually. We've pretty much had every specialty that's ever been offered represented in the cadre. Once you complete your primary residency, you then do a fellowship that is 2 years in aerospace medicine. Once you complete the fellowship, you then get hired as either a contractor or as a civil servant. And then you have to do more NASA-specific training to ultimately get your wings as a NASA flight surgeon. There is one other track at UTMB, University of Texas Medical Branch, in which you can do a combined residency in internal medicine and aerospace medicine. So you become dual boarded at the completion of that residency.
Hey, Sean, do you want to pop it into presentation mode?
Yeah, help me do
that. It should be in your
slideshow.
Bottom right. Yes, that's it.
Okay. How's that? Did that help?
Yep, that's fantastic.
Okay. So, so what does a NASA flight surgeon do? So I'm one of the few actual flight surgeons who is an instrument-rated pilot. So one of our duties is we do fly with our crews in the T-38, which is in that top left-hand corner. We do practice medicine, which to the right is the Flight Medicine Clinic. We also support the Nutribuoyancy Lab, which is the world's largest pool, if you will. And that's where they practice for extravehicular activities as well as testing of new vehicles. In the center, we also support mission control as a flight controller. And then since Colombia, we've been going to Kazakhstan and Russia to retrieve our crews from the Soyuz vehicle. So there we go, mission control. There's also a space vehicle mock-up facility where they do training, the Nutribuoyancy Lab. There's also a vacuum chamber at Johnson Space Center, and so we support vacuum austere environment testing with the crews. And then Star City, Russia, which is one of my duties, where we support our crews getting training on Russian systems. So space radiation. Sorry, my mouse is very sensitive. So right now, all our operations are in what's called low Earth orbit, or LEO. And our crews are protected by the Van Allen, the geomagnetic of the Van Allen belts. We're going to be going to the moon here before too long in 2024, and we'll be exposed to much more higher levels of space radiation. So there's ionizing radiation, which is obviously sufficient energy to remove electrons from atoms and can cause damage to the DNA, and I'll show you that here in a second. And then there's the non-ionizing radiation, like electromagnetic. So we also have galactic cosmic radiation, which is high energy radiation from metal atomic elements and other. The trap radiation is what we see from the Van Allen belts and just radiation exposure from our planet. And then there's solar energetic particles or flares that cause high energy ionizing radiation. The galactic cosmic radiation originates obviously from outside the solar system. It's particle radiation at high velocities. It also very penetrating. And so it goes right through the vehicles. As far as our trap radiation, it's just basically, Earth's magnetic field traps these particles, but also from the solar wind. This is a threat for our crews traveling through that magnetic field. So again, we're talking about the geomagnetic fields of the Earth, and you can see the South Pole, North Pole, and that magnetic axis that is slightly tilted. On a side note, besides being a NASA flight surgeon, I've also been a polar expeditionary surgeon for the South Pole Station. And so I've actually been to the South Pole and lived there for 6 months and got to experience that interesting austere environment. Just one quick note. I'm going to go through these slides pretty quickly because we have a lot to cover, and I want Katie to be able to talk about the clerkship. She will get you my email and contact information so that if any questions come up later besides just today, I'm always available to answer any questions for all of y'all. So again, we talked about the Van Allen belts. There is an interesting hole, if you will, called the South Atlantic anomaly that allows a lot more of the radiation in. And the vehicle, the International Space Station, does transverse that section on a fairly regular basis. So they do get a little more exposure when they go through that anomaly. So talking about solar weather, that's a really big thing that we watch. It was really interesting when I got my NASA training. We had a lecture on just solar weather. Interesting enough, it's just like the weather you hear on the news every night. And the NOAA website gives you predictions and energies and the winds and predictions on solar flares. Solar flares are just large eruptions of electromagnetic energy from the sun. Usually has no direct impact on the crew. Coronal mass ejections are large expulsions of plasma, and that can cause geomagnetic storms that can actually affect aviation terrestrially. And then what we have, and if that big, the coronal mass ejections are most concerning is when they go outside of the vehicle during an EVA or a spacewalk. Solar energetic particle events are high flux of protons, and that is something where if it occurs, the crew will have to go into what we call the safe haven, which is a section of the International Space Station, usually covered in large containers of water. Water is an excellent shielding against this type of radiation. We always take the ALARA approach, or low as reasonably possible, as far as radiation exposures. Why? Any exposure, no matter what, it still reaches a threshold of potential cancer risk. So we measure every single possible measurement of radiation in an astronaut's lifetime career. So, how do we protect against radiation? Basically we start with elimination, is just avoid the exposures, trying to keep them out of the South Atlantic anomaly as much as possible. Try and keep them away from polar transverses, which they really don't do at all. Then there's engineering, trying to design radiation resistant areas. Administrative is, trying to plan around weather and when we can predict, keep the exposures decreased as much as possible. And then protective, PPE, which with COVID, we all know that by memory. We also monitor them with detection devices and actual dosimeters that they wear when they're on orbit. So let's trans to space physiology. Basically, you take what you learn in medical school and you start all over. Everything in the human body changes when they go into the microgravity environment. Right now, the biggest, and I'm going to just go from top of this picture and I'm going to rotate clockwise. So the eyes right now are having significant changes, and it's probably the biggest area of research with a condition that some crews developed called SANS, S-A-N-S. I'll explain that a little later. When you go into microgravity, the otoliths float up, and that causes your sensory neurovestibular system to really change and causes significant effects, both going into microgravity and then coming back. There's something about microgravity that just does cause the brain to have changes. I'll go on that in detail later. Kidney filtration changes, especially it increases. You have fluid redistribution. You have touch and pressure sensor changes. You have muscle and bone changes, especially in weight-bearing areas of your body. You have a blood plasma shift, and you also develop a slight anemia. You have slight increase to cancer risk, and then just the fluid shift can cause congestion and changes in facial features. So we've just kind of talked about this on that previous slide. Here's a good graph showing you the timeline where there's adaptation syndrome. If you'll see, if we go from left to right, the first thing that happens is the neurovestibular system changes, and that's where the otoliths floating up. And basically, the sensory system becomes hyperactivated. The next is the fluid shift, and that occurs very early on as well as the cardiovascular system. Your red blood cell mass is one of the slower changes, and then your bone and calcium metabolism you see is a linear change. So really, within a month and a half or so, they really have pretty much adapted as much as they're going to. And then over 6 months to a year, you have this just very slow, gradual change and decreases in those symptoms, except for the bone and calcium metabolism, which continues on that linear line. So neurovestibular effects. The sense of orientation. So if you look at this picture, my question I'm going to pose to you is, who's right side up and who's upside down? Because if you look at this picture, you'd say, well, the fellow in the white t-shirt is right side up and the fellow in the blue shirt's upside down. Well, what if I rotated this picture 180 degrees? It doesn't matter. There really is no specific orientation. When crews first get up on orbit, their visual concept of seeing this type of image doesn't make sense to the brain because we're terrestrial creatures. And it causes a lot of brain activity, which causes overload, which leads to something called space motion sickness. Balance and posture changes because of the neurovestibular system, as well as the lack of gravity. And so your body changes to that microgravity environment, and the muscles revert to, and the body reverts into positioning that's more comfortable for microgravity, which would never happen in a terrestrial environment. It's kind of hard to explain, but they almost, you'll have to look at the videos when they translate, and that's the best description I can give you. But if you look right here, they're not crunched up. Now they're crunched up a little bit because of the space, but that's actually kind of their natural posture. The arms tend to be a little flexed. The legs tend to be a little flexed. And that's how they basically revert to a microgravity environment. So let's talk about space motion sickness. 79% of crews get some type of symptoms. Some are mild, some are moderate, and then in some cases, some people just really have a hard time adapting. There's no real factors that we can predict who and who will not get it. Males versus females, it doesn't really matter. We do see that the veterans tend to be less symptomatic than first-time flyers. It usually resolves in about 48 hours, maybe sometimes a couple of days to a week. Things we can do to treat it is try and keep everybody in the same orientation. As you look in this picture, you know, everybody's got an up and down. They're all on the same plane, if you will. We have medications that help. Decrease stimulus, so not, getting some sleep, not having to visually look so much. There are some pre-flight adaptation training. One individual would sleep with the head of his bed down by a foot. He said that really helped. There's some chairs that the Russians use that they spin them at a certain frequency, and they think that sometimes help, but we don't have any really hard evidence. So what happens when they come back? Well, they have the exact opposite change when they come back as they do. Well, they have the same change when they go up as they come back. When those otoliths come back onto the floor of the inner ear, the stimulus stops for a while, and then it is hyperacute. So if they turn their head to the left or the right, they get hyperstimulus, which causes severe nausea and then ultimate vomiting. We jokingly call they have their gyros locked. It's just too much stimulus. So they get vertigo. They have a hard time being able to walk. And they kind of describe it like, the game where you stuck your head on the top of a baseball bat and spun around 10 times and then tried to walk. That's exactly what their sensation is. I'm going to skip some of the pursuit tracking and right now, but you can see from the graph their visual ability to target and gaze is significantly affected. So let's talk about fluid shifting. So we're terrestrial creatures, and so on Earth, our heart, besides circulation, its main job is to make sure that blood from our legs and our lower extremities gets pumped up to our brain. So when you go into space, it doesn't have to do that anymore. So all the blood shifts from the lower extremities to the upper extremities. What that does is it causes the heart to stretch. When that heart stretches, it senses that it's overloaded with fluid, and it has a hormone called beta natriuretic peptide that causes the kidneys to decrease that volume load. And so they diurese, or they urinate about 2.5 to 3 liters out of their system, which causes the heart to go back to a normal size. And as they're in that microgravity environment, they are now what's called normovolemic. So if you go to A, they're normovolemic. When you go to picture B, they're hypervolemic. If you go to picture C, they're normovolemic for a microgravity environment. And then when you go to D, when they come back to Earth, they are hypovolemic. And that is, they're 3 liters low. And that can cause significant changes in blood pressure that ultimately affects ability to get blood to the brain. This is Kjell Lundgren. He was a NASA flight surgeon who became an astronaut. If you look to the left, that's his terrestrial appearance. And then when he got on orbit, you can look at him, you can see that fluid shift up into the superior aspect of the body. So what we were talking about in the couple of seconds, so when they come back, they're really low in volume, and it causes something called orthostatic intolerance. In other words, they can't stand up without getting dizzy. This is important because an emergency egress is much, much more difficult at that point. Again, if they stand up too quickly, they get the feeling they're going to faint. Countermeasures we use on orbit is aerobic exercise. We have a fluid loading protocol right before deorbit. We keep the crews on their backs when they come back. We have G suits or garments that help compress the lower extremities to try and force that fluid up into the upper part of the body. I'm going to skip over this. I'm going to cover it, but I'm not going to go into detail since we're a little short on time. This is usually an 1.5 to 2 hour lecture. So, but the big thing we're looking at right now is something called spaceflight associated neuroocular syndrome. It was formerly called another acronym called VIP that we don't use anymore. But basically, it's an alteration in the ocular anatomy, possibly due to increased intracranial pressure, that changes the optic nerve sheath and cause flattening of the globe of the eye that can cause a change in their vision that's permanent. This is the leading part of research right now for space flight and space physiology. Another thing we look at is the musculoskeletal system. Since they change the way they use their muscles, it is kind of a use it or lose it phenomenon, and the muscles tend to atrophy because they're not having to walk. Mostly we see it in the back, hips, and legs. The other thing is, because the body isn't being gravity loaded, the bone metabolism changes, and we see demineralization mostly in the lower extremities and the spine. But we also see an increase of diuresis of or urination of the calcium out of the body. One of the things we get concerned about with that increased altered calcium metabolism is it can create kidney stones. The other concern is, as the bone is going through a different physiology, the risk of fractures increase. This is just a graph showing where the largest amount of bone mass density changes. And you see the pelvis, the lumbar spine are the main ones. So how do we do to countermeasure that? The crews have 2.5 hours of exercise daily. They either use a treadmill, a cycle ergometer, or a weight resistive device. And you can see kind of the graph. Oh, this thing is so sensitive. You can see the graph below what all these 3 devices offer as far as countermeasures. The CO2 on orbit is almost 10 times the level of terrestrial CO2. And the reason for that is it's just a large expenditure and limited consumables to get it down to that level. So in a terrestrial level, it's 0.04%. However, on ISS, we maintain it at 3 right now. Large fluctuations in this can cause symptoms, specifically headache, kind of slow dullness in calculations and procedures. I'm going to skip over this just because it's a slide that you'll have access to, but these are just basically what you see when you see high levels of carbon dioxide. So medical care on orbit. We, as flight surgeons, when we're assigned a crew, we'll take care of that crew from pre-flight, in-flight, and post-flight. We support console from 7 a.m. to 4 p.m. Monday through Friday, and then we're on call 24/7. We have a private medical conference every week. They have private psychological conferences every 2 weeks. They have a exercise conference with their strength and conditioning specialists once a month. And then they always have the IP phone and emails at any time. We also do periodic health fitness evaluations pre, during, and post-flight, and especially pre and post EVA. On orbit medical testing, we do eye evaluations, hearing tests, body mass measurements, cognitive assessments, physical exams, and if they ever have a problem, we're there to support those tests as medically indicated. We also go to the team meetings that manage the mission, and we also support them as the crew advocates for their research that they're subjects to. EVA is probably the biggest and most risky activity they do when they're on orbit. There's concern of decompression sickness because they go from a pressure change of sea level, which is 14.7 psi, to the spacesuit, the EMU, to 4.3. And they're also in 100% oxygen environment. With that reduced pressure, they're concerned of DCS or nitrogen bubbles releasing into the bloodstream and tissues. DCS can range from just mild joint pain to unconsciousness and death. Prevention is 100% pre-breathe of oxygen to wash out as much nitrogen as possible. We have a system to calculate the level of symptoms. We call that a cuff class. And there's a level from 1 to 4. And then as far as treatment, it's repressurization, and in dire need, we have an apparatus that can change the EMU into an actual recompression chamber. Other concerns we have about is increase in CO2. We have had an event where the suit failed and water leaks into the helmet. And then we've also had an event where there was a rapid repressurization that can cause a rupture of the tympanic membrane through the eardrums. Decompression sickness, we just kind of talked about. Embolism is where the blood actually releases to gas. And the best way to explain that is if you were just to open up a Coke can really quickly after shaking it, and all the liquid comes out as foam. And that can happen to the human body under rapid decompression. You know, the space suits, the EMU, are really pretty tight, and they cause a lot of hot spots, if you will, that can be irritating. The fingers can delaminate. We've had shoulder injuries because if it's not fitted just perfectly. And then there's also the option or chance of barotrauma with the pressure changes. Behavioral health, we do a lot of things to try and keep them happy and healthy. They love looking out the window. They love taking pictures. Exercise is always a good release for them. They love getting care packages from the transport cargo vehicle, especially fruit and vegetables. They have time with their family. And today we haven't really had any issues. We watch them very closely, but that is a large part of our support. As far as common conditions, we've talked about space motion sickness. Their sleep changes. Some sleep more, some sleep less. The fluid shifts cause congestion, so they love hot sauce to keep their sinuses clear. We see headaches, nearly 100% of all crews. They're usually mild. It's either due to fluid shifting or possible CO2 exposure. We see some sprains and strains from their exercise activity, common minor cuts and abrasions from bumping into stuff. They don't get to bathe on orbit, so skin rashes are a very common problem we see as well. As far as our medical capabilities, we have ultrasound, we have medical kits, oxygen, we have IV fluids, medicines, we have an EKG, we have splinting and wound management. Basically, everything you would find pretty much on an ambulance would be the closest way to describe their capabilities. So when they come back, well, for now, on a Soyuz, but as of a couple of months ago, we're now using SpaceX, where they're coming back to the United States. This is just a picture of approximately where they come back in Kazakhstan. That's the crew in the Soyuz. It's a tight fit. They land in the desert during the winter and the spring, and you can see they could be landing in snow or just in the steppes of Kazakhstan. This is just a quick overview of the landing sequence. The biggest thing is they're absolutely exhausted when they come back, just physically and mentally. They have decreased aerobic capacity. They're slightly anemic. They're dehydrated. They have low blood pressure because of the fluid shifting. The neurovestibular changes come back when they come back. The capsule gets very hot, not overly, but it gets hot enough where they sweat, and that compounds dehydration. In the winter, it is extremely cold, so they have risk of hypothermia when they get out of the capsule. The capsule lands on land, and it lands hard, so potential trauma. I'm going to skip this for right now. But what we can do pre-landing, we have the fluid loading, we have medications, and then we have G suits that can help force that fluid up into the upper body. I'm going to skip some of this because you can open it, you can read it yourselves, and we're short on time. This is the capsule when it's landed. It sometimes lands just straight up. Some affectionately call that the gumdrop pop because it looks like a gumdrop and it looks sitting up, but it can land on its side. This is them being extracted from the vehicle. They're placed in a chair. They're about 20 to 30 minutes to adapt. We put them in a tent. If they're really ill, they go straight to the tent. We get them out of their suits. Here they are, public affair event, and then they get to talk to their families, let them know everything's fine. Then put them in the medical tent, do some tests, probably put an IV on, give them some IV fluids, get them dressed. Then they come out of the tent, get in helicopters, and they go straight back to Houston or Russia. We used to keep them in Russia for a couple of weeks, but now we have direct return where we send them just directly back to Houston. They go from orbit to Houston in about 24 hours. Again, the symptoms we've kind of talked about: nausea, difficult walking, dehydrated, lightheaded, might have some bumps and bruises, just absolutely exhausted. this is just some, I skipped through some of these. These are just the vehicles that they go and come on. That's the G5 where they can lay down and get a little rest before they get home. Post landing, they go into a quarantine facility. We, eat, drink, fluids, immediately start getting them into reconditioning. In the gym, the pool, we have a multitude of equipment to help them readapt. And then they start their mission debriefs. This is a place that's affectionately called Star City. It's a very place near and dear to my heart because I've spent so much time there. It's the counterpart to Johnson Space Center in Russia, right out about 60 kilometers outside of Moscow. These are just some pictures of what Star City looks like. That is the picture on the high left is a place affectionately called a prophylactorium or Profi. It's a quarantine facility for the Russians. The crews live in cottages, and that's to the right. And those are the two places in the winter. They have mock-ups of their Soyuz, they have mock-ups of their mission control, and they have a huge centrifuge that they use for training. They have a pressure system to test the Sokol suits, a hypobaric chamber, and then the picture in the bottom right is the specialists that make the special seat liner that you can see on the left. They do water survival. They do winter survival. And then that's some of my colleagues in the microgravity plane that we used to use, affectionately called the Vomit Comet. So I went through this pretty quickly because I wanted to be able to answer some questions. But again, like I said earlier, if you have any questions, just get a hold of Katie McMahon. She has my information. And I'm happy to talk to you by phone. I'm happy to talk to you by email. I'm also one of the physicians that's responsible for training and the clerkship. So I can help with those questions and just anything in general. It's been a real pleasure to talk to you guys, and I'll take any questions.